CTO intervention. He'll be talking about CTO. Actually, he told even though there are 5 topics written, I will make it a 3 and then make a clear understanding. I think we will be asking questions in between. Okamura?
Okay, yeah,
thank you.
It's a great honor for me to be invited here, and especially thank you for Dr. Kumar and Dr. Aji. So I talk about 3D wiring. Mainly, I talk about tip detection method. Yeah, I separated 3 parts. Yeah, during the progress, I will change or something. But anyway, I'll talk about the concept of 3D wiring, tip detection. What is 3D wiring? 2D wiring, advancing wiring, utilizing 2D information with an operator tactile feedback, like this one. This one usually mainly performed during the CTO intervention, like this one. Just try and no, just try it again. 3D wiring, advanced guide wiring, utilizing real-time 3D information from fluoro or IBIS images like this one. You advance a 3D construction, counterclockwise, and penetrate. This is 3D wiring. So if you manipulate the guide wire while recognizing the proper rotational direction, torque direction, wire direction, you are performing 3D wiring. Otherwise, it is 2D wiring. So the guide wire movement in the CTO region is pivot-like movement. The shaft is fixed and tip rotate around the shaft. Oh, okay, so maybe it's better to this one, laser pointer, okay. Pivot-like movement. Then the 3D wiring is needed to accurately navigate the guide wire tip to a target using this pivot-like movement. We have developed the 3D wiring using fluoro IBIS to perform accurate penetration to the target, like this one. So this is the progress of 3D wiring. First we developed fluoro-based 3D wiring, then we developed IBIS tip detection into the plug tracking 3D wiring, then we have reached tip detection ADR. So after TD-ADR, after 2020, we have performed 350 CTO cases in our hospital. The success rate was 97%. The final crossing strategies are AWA 67%, retrograde 8%, tip detection 22%. So the tip detection intra-plug tracking and the tip detection ADR, the percentages are almost 50-50. And the success rate of these tip detection methods are both of them 97%. So shortly I'll talk about fluoro-based rewiring. But it's not good enough time to explain this one. But this is a main, this is a very important concept. If you see the 2 images, the image is the mid part of the RCA. So you have to construct this 3D image in your brain in 1 second. But this is impossible. So that's why it's better to use 3D imaging, same front, opposite back. So if we understand this simple theory, you can navigate the guide wire tip to a target like this one. So this is the Asahi ethos model to train CTO wiring, including the 3D wiring. This is 2D wiring. The guide wire tip is directed target. This one is the target. The one view, yeah, maybe okay, but the other view, no good. One view okay, but the other view, no good. There is a 50-50 chance. Sometimes it's okay, sometimes it's not good. But finally, you can get a target. This is the usual practice wiring in the CTO intervention. But finally, yeah, you can get a target. This one, trial and error. This is 3D wiring. This one I used 3D image, front and back, on the back and front counterclockwise. And this one back and front counterclockwise. Front and back a little bit clockwise, and back and front clockwise, and the back and front clockwise. So I understand the rotation. So definitely the guide wire tip is going to the target correctly like this one. So if you understand that this theory, yeah, please see the YouTube video. I will explain also in English. My English isn't good, but maybe I can tell you. So next I'll talk about the IBIS guide. How to construct the 3D image during the IVAS guide. The first guide wire is already in the subintimal space. Just now the IVAS is a subintimal. You are watching. Second guide wire from the cyber IVAS are subintimal space. So this is a cross section. This is the IVAS image. IVAS is subintimal space. The second guide wire is there is an interfractal. If you navigate the second guide wire into the center part, which rotation direction of the guide wire torque? Clockwise or counterclockwise? The answer is undecided. Because if the guide wire tip is directed right side, you should rotate it clockwise. But if the guide wire tip is directed left side, you should rotate counterclockwise. So tip observation is essential to perform 3D wiring. That is the tip direction method. So to perform tip direction method, we have developed an IVAS, short tip product IVAS. But you only have optical IVAS. So sometimes you have to cut the tip of the optical IVAS like this one. And IVAS, second model, good pushability, short tip, full product system. So this is for the CTO intervention. So, but still optical IVAS can see the tip. This is the anterior IVAS experimental model. The tip is directed to this direction, 11 o'clock, but the tip is also can be recognized by opticals. Maybe this is the 11 o'clock. Some irregular reflections are there, but still you can see it. And sometimes MDU of the opticals is very rigid. Dr. Fujita told me that you should use zip tie to unlock button to be on, like this one. This is free. And also, if the short tip, it is very difficult to advance into the CTO region. You have to use the balloon, 2 balloon, 1 balloon. Any balloon is okay. Just push it from the back side of the monorail lumen, like this one. Then leave it and do the tip direction using the product system. So selection of guide catheter, more than 7 frame guide is needed, and 8-field catheter is much better because IVAS, microcatheter, anchor balloon are included. So microcatheter selection, tip direction intraplug tracking, regular microcatheters are okay because the microcatheters are supported inside the CTO tissue. But if we perform TD-ADR, metal microcatheters are much better because these microcatheters inside the subintimal, free space. So that's why there's enough backup support is needed if we perform the re-entry. How about the guide wire selection? Focus 12ST is much better during both cases, situations, but the 20 gram is okay. I did it before the TD CP12ST coming. And also the guide wire shape. Distal part first curve is the same as the CTO, a guide wire shape, 1 millimeter, 45 degree. But the second curve, maybe 5 degrees formation is better. If we perform the interplug tracking and ADR using a tip direction method. So, and also the appropriate tip visualization is very important. If you see the guide wire tip like this, you will advance the transducer in the distal part. This is shaft. This is tip. Tip is going to the maybe the 6 o'clock. But it is not true because if we advance the transducer a little bit more, the guide wire tip is sometimes bent or like this. So then after that, if you advance more, nothing. So this means that apex of the tip is directed at 9 o'clock. That's very important. So tip disappearance technique is very important to show us that the tip is which direction the tip is directed, like this one. So this one, I advanced the guide wire transducer to the distal part. Which direction the guide wire tip? The guide wire tip is disappear here. So this means that the tip is directed this direction. How about this one? This one, guide wire tip is disappeared here. So tip is directed to this direction, maybe 4 o'clock or something. This direction. How about this one? This is obstacles. So which direction the guide wire tip is directed? This one, the guide wire, the tip is this direction. No, this is reflection artifact. The guide wire tip is directed this direction. If you can identify this direction, you can do the tip detection method. So the tip truncation and also don't be misled by the reflection artifact. That's very important. So yeah, maybe time is not enough, but are there any comment or something?
Yeah, actually telling you, we should look at only two parts. One is actually the shaft and the tip only. But you are telling we have to go to two projections. One is RAO30 and LAO60, right? You are telling it is okay to use even a opticross catheter. Not, and the owl is not always compulsory, right?
Yeah.
But two important things. In a osteoproximal part, the CTO should be in the mid segment. If it is in the osteoproximal part, then how we can do that?
You mean that's entrance?
No, the CTO is totally in the osteoproximal part. That means origin of the vessel itself. Then it will not work out, right?
So yeah, that is one problem. So that's why the proximal part, maybe the RCA ostium, yeah, sometimes it's very difficult because the backup isn't enough. Yeah, that's right.
So it is actually a little confusing, but I think I tried to learn from him, along with him, then learning. I took a lot of time to learn from mugging up, but even then, really good brains are required. So Okamura has a brain which is beyond our level, but I'm trying. I think Himanshu has a better brain. You want to ask the question?
My brain is not better. I have a doubt. So Sensei, when you do tip detection ADR, the one wire and the IVUS catheter both are in the false lumen, and the wire is beyond the CTO. So we can advance the IVUS catheter on the false lumen wire. When you do tip detection intra-plaque tracking, so on which wire is the IVUS catheter? Because the wire will be obstructed by the CTO lesion distally. So on which wire are we moving the IVUS catheter in intra-plaque tracking?
So yeah, usually use the first guide wire. Maybe the intra-plaque root was stopped here. Maybe I leave it. Or sometimes I advance the Corsair. Yeah, Corsair advance it and change the guide wire to UB3 or some intermediate wire. I leave it. Then advance the IVUS into here, and the second guide wire is A20 or the ST.
But actually, you are talking about the first wire.
Yeah. The first
Where
wire
the
is
IVUS catheter is
First wire is basically you move to tip detection ADR when your wire is subintimal.
subintimal in the
That
CTO
first wire
body.
is in subintimal.
Yeah.
Your
Just the
IVUS is
catheter
on
is
that
in-
wire.
The catheter has not
No,
gone
not in the
subintimal,
CTO
the
body.
wire is subintimal.
No,
the
not
first
in the
wire.
CTO body. It's First beyond
wire
the
is-
subintimal. IVUS catheter is on that wire. You are taking a second wire,
The
right?
IVUS
And
has
then-
not yet gone subintimal. So because that is why we call it intra-plaque tracking. The IVUS, the wire distally will be subintimal in the CTO body,
That's
but the IVUS will be
basically
in the,
ADR is like re-entry.
Yeah.
The other one is anti-grade wiring.
like parallel wiring with IVUS detection.
Yeah.
There are two, three actually. One is actually only the 3D wiring, which is totally luminal, what he is trying. The second one is actually already subintimal and going into the true lumen later.
No.
So your IVUS has to be beyond the
You are
distal
right.
path.
If
Distal
you
path.
go your proximal IVUS.
Okay,
will
so
be-
yeah, I will go to the next.
Then it will go.
One more comment,
And everything
Okamura.
starts only when you are.
If we have an IVUS catheter which can image that 3 millimeters of wire simultaneously, I think everyone in the hall will understand what is tip detection idea. Is that possible? Having an IVUS catheter which images the 3 millimeters of wire tip continuously and keeps in front of you. Yeah, generally any ultrasound is one slice. Ultrasound is one slice. That's what I'm saying. If you can do a catheter, which images 3 millimeters, just like CT, you have made an entire something like a 3D echo probe.
No,
That's
wait.
a different subject. I think Okamura can go ahead again.
Okay. Sorry. So I will go next. Yeah, the proximal cap puncture. So this one navigates this one navigates the guide wire tip to the target. The CTO region is the entrance of the bifurcation. You should leave the IVUS here So you navigate the second guide wire into a two lumen, like this one. In this situation, even you can use tip detection method. This is the guide wire shut and this is tip. The tip is directed to this direction. This is the two lumen entrance of the CTO. If the guide wire tip is going to this direction, you should rotate clockwise. If the guide wire tip is going to this direction, maybe the sub-intima counterclockwise. So you should choose clockwise rotation to navigate the guide wire tip to the target. So even entrance, you can use the tip detection method. But sometimes it's very difficult to advance the tip to the two lumen. There is a classification here. So your guide wire sometimes navigated should be into the sub-intimal space intentionally. This one. So try to navigate the guide wire tip into intra-plug route first, but the difficult navigate the guide wire to extra-plug space like this one. This is the case. LCX CTO already was unstable angina culprit, and I told it already and put the stent. Then this is the UA unstable angina. In 2 weeks, I did intervention for the LCX. They are very small collateral channels. So I tried to navigate the guide wire tip to here. This is the entrance of the LCX, very classified. The guide wire could not be entered into the center part of the classification. So that's why I intentionally navigate the guide wire tip to the sub-intimal space using a tip detection method. Then I did knuckle wiring, and I did a re-enter from here, TD-ADR. So navigation of the sub-intimal space is also okay if you can do the tip detection method or retrograde approach or stingray. But anyway, I put the stent and I referred. The next one is I'll talk about tip detection intra-plug tracking. So how to prepare for the IVAS guidance. So first, the Dr. Gupta told me that I try to do 3D wiring, then get a target like this one. But if we fail it, I have to advance the corsair or small barrel dilatation to make the space to deliver the IVAS. Then I delivered IVAS and delivered microcatheter and second guide wire here. Sometimes this guide wire is a compressed or something. During this step, I will change the guide wire into UB3 or this way. But anyway, we start tip detection intra-plug tracking first, but difficult, switch to the TD-ADR. So these are tips and tricks of tip detection intra-plug tracking. So first, it's a little bit difficult to explain, but the fusion is important. Transfer the spatial information from the iris to lumen sphere to the floor image. So this is important. Then you have to do the tip detection. This is the second operator's movement of the hands. Back and forth movement, the second operator show me the tip direction, like this one. Then I wrote the guide wire tip correctly to the target. So this back and movement is very important. Then clockwise, then the guide wire tip is going to the two lumen, like this one. That is the tip detection method using the iris. This is like a Google Maps navigation. So there are some tips. So this is IVAS, this is the clarification. IVAS divides the space into two parts, right side or left side. You have to consider right side is better or left side is better. In this situation, there are some luminous spaces, it's better to choose a right side. And another thing is you have to use the IVAS classification to increase the backup force of the wire. So you have to hit the IVAS first, then penetrate to the target. You can get enough backup force to the target. And also classification can be also used like this one. This is the another techniques. So I will show you, this is the experimental model. Sound is on, please. Sound.
Voice.
Sound.
Audio.
We are planning to rotate the guide wire counterclockwise to advance the guide wire to this loop to the target.
That's some.
The tip was rotated counterclockwise. Please pull back the guide wire because the guide wire tip is going to behind the IBUS. It's okay. Guide wire shaft hits the transducer and the tip is directed downward. The target is here, left side. A little bit pull back and clockwise. Shaft hits the transducer and the tip is this direction. The target is here. Clockwise. So you rotate clockwise. I rotated clockwise. A little bit over this direction, please advancing. A little bit counterclockwise. Please check the guide wire tip continuously. The guide wire tip is directed to 7 o'clock. You can see the shaft hits the transducer and the tip is directed here. In this situation, this is clockwise. Please rotate clockwise. Just now, it was rotated clockwise. Shaft hits the transducer and this direction, 730. Direction is 730. The target is here. This direction is okay. Or a little bit counterclockwise to the center part of the target. A little bit more counterclockwise. You can see the guide wire tip is on the target.
Yes. So this is the tip detection method. So I will show you the real one. So this is the RCCTO. There was some vendor. So at another hospital, they tried to do the integrated guide wire and navigation, but they failed. They used 3 hours, but it was impossible. It was impossible to get the navigated guide wire tip to the target. So the patient was sent to the next intervention in a hospital. I tried to do the AWE, but the guide wire was also in the subintimal space. Then I advanced until I was, and the second guide wire is supported by the Corsair. Then I will navigate the guide wire tip to the to room using a tip detection method. This is also a video. Okay.
Dr. Okamura,
Yes,
please
yes.
give
Yes, yes, yeah. I already advanced the compressed wire using a 3D wiring. Then I did the iris. The wire location was very nice. So firstly, we have to use the compressed wire using the 3D wiring because the Gaia gradius is not accurate guide wire calculation. But anyway, Dr. Suzuki will explain the iris.
This is the IBUS image, and the Conquest Pro advanced into the vessel, but the distal toolman is shown here under the IBUS catheter. And the first guide wire on the IBUS guide catheter is shown here, and the Conquest Pro ST, you can see the tip of
Okamura,
the
this is actually
Pro
totally
ST.
true lumen. Even the IVUS is in the lumen, right?
Yeah, this is the two lumen, but this is the rear distal two lumen, but this is the
It is,
IVUS is actually
it is intra-plug, but not
yeah,
in the lumen.
intraplug, but not inside the distal two lumen. Yeah,
plug, but away from
Not in the lumen.
Okay, so please turn on the light.
It's Vijay, that is the collapsed part was the true, that part. Okay.
Clockwise. Clockwise. Counterclockwise.
Which?
Okay, any clockwise, while clockwise, advance into the lateral movement. This lateral movement, okay. And just more. A little bit clockwise, advance, clockwise, advance. Okay, clockwise, okay. I got it.
So I changed my advanced guide wire more and change the guide wire to a soft one, and I refloat just 1 hour. So this is a very precise guide wire navigation using the IBIS. So maybe the time is limited. I will go to the next one again. Directly tip direction ADR. So it was.
Okamura, actually, I have a doubt. Once you are in the intra plug, even if it is not in the lumen, we can track the wire and get into that, right?
So you mean that flow navigation?
We are in the vessel, but may not be in the lumen. But even if you are in the vessel, actually, we can manipulate the wire and get into that.
There's a possibility, but this is a failure case. Maybe they tried to do it, but they couldn't reach the distance to limit. So that's why I directly go to the tip direction.
Yeah, subintimal is a real game, but in
Yes. Inter-block route, there's a possibility to pass the guide wire at the distance. Yes.
In subintimal to intimal entry, you have to take a tougher wire like either Conquest Pro ST, which is actually available with you. We have to take a Conquest Pro 12, right?
Yes. Conquest Pro 12 is also okay. 80 is much better.
820.
820. So I will go to the TD ADR. It was blindly assumed that ADR was impossible with IBIS guided wiring. IBIS guided wiring was thought to be the intraplug clocking, like this one. So this one, ADR using IBIS was almost impossible. It was thought. So therefore the stimulus system was developed, but its success rate was only 60 or 70% because this is a fluorocide. So that's why it's not accurate. Standardized ADR, once thought impossible with a stingray, is possible with the tip detection method. This one, subintimal, if you penetrate like this direction, edge or calcification, you cannot penetrate. And also, if you penetrate not in a vertical direction, you cannot penetrate. But if you do perpendicular penetration to the ideal point, by tip detection method enables reliable re-entry, like that case. So this one, a little bit counterclockwise, the tip is directed to lumen, a little bit counterclockwise, and then push it. This is a 20 wire. Then you can get a target, like this one. This is a very precise needle puncture using the IBIS intracoronary image, like this one. So this is the first case. I did it 2019. The patient was transferred to a hospital to receive LAD CTO lesion and right coronary stenosis and diagonal branch. This is a 20 years old occlusion of the LAD. RCA is a new lesion. So I fixed it RCA, diagonal, then I tried to do the LAD intervention, 20 years old occlusion. So the entrance is here. This one is the full moon classification here. So this is the distal, around the distal, here is the distal part. So I tried to navigate the guide wire to this one, but the conquest could not be passed. So I did knuckle wiring using the gradius. Then I tried to do the stingray. Maybe I tried several times, 5 or 6 times, stick and swap, but I couldn't get the two lumen. But I have an anti-rival, so I saw this area. So I saw two lumen here, and maybe some damage started here. Maybe the stick by the conquest wires, so something. So I thought that it could be possible, might be possible to navigate the guide wire tip to here, some damaged space. So I tried to navigate the second guide wire, but during the tip detection method, I instinctively do the penetration, not this part here. Then the guide wire was entered the two lumen. But anyway, this one, the guide wire gets the digital toolman and I put the stent. So yeah, we finally reached the TDADR here, like this. So this is a failure kills a stingray, but I could do it. So these are tips and tricks of TDADR. Long axis view, recommended puncture site is from here, just beyond the CTO exit until the first main branch, except for the classification region. But if the CTO exit is located at the bifurcation or prevent a long subintimal passage, yeah, it's better to re-enter from the CTO body. So compared to the stingray, tip detection method enables re-enter to the CTO body. That is another advantage of this one. And this is a long access view thinking about bias assessment. This is a privacy here, subintimal space to remain here. If you advance second guide wire, your guide wire is maybe similar, same position of the iris because this is an open space. So if you think about that, which patterns has a higher success rate among these patterns? IBUS to remain here. So high success rate is this one and this one. Because IBUS and toolmates are very close, this one is also, this is a far away. If we advance a second guide wire into the open space or subintimal space, your second guide wire is very close to toolmate, so you can easily penetrate. But if we advance the second guide here, your second guide wire are here, so you have to make the more big, larger curve. So this is a little bit difficult, or sometimes impossible to penetrate. So you have to see the IBUS bias against the two lumen. So this one, I did it. A little far away, TDADR far away. Sometimes it was difficult. I tried it at distal part, two lumen, and the IBUS is close. Then I could easily navigate the guide wire tip at a two lumen like this one. So bias assessment is important. To do the to get the high success rate of the TDADR. So the another one is short access view thinking, mechanical considerations. So this is a two lumen. If you see that you try to do the ADR, TDADR like this one, but success rate is 50-50 because guide wire will be deflected and the two lumen is deflected like this one. So you have to think about 6-point approach. First, the IBUS here, you have to hit the IBUS first, like the intrapractical, then penetrate the two lumen. So this one, the guide wire is not easily bended because this is supported by IBUS. The next one, the lateral puncture and the posterior lateral puncture. This advantage is from here to here shorter compared to here. The guide wire is not easily deflected, both of them. And also, from the lateral or posterior lateral puncture, the two lumen is not easily deflected because it is anchored by the median. From here, this is easily deflected, but from here, the two lumen is not easily deflected. So that's why lateral puncture is much better. I saw your case. Your case was the lateral puncture. So, and also you have to think as a morphology. So two lumen, nice one, easily deflected. But some classification or some club or CTO body or protrusion was already compressed or the side branch allocation, that is a good candidate for the TDADR. So if you decide to do the TDADR before the final puncture, you have to see the fluoro and check the allocation of the microcatheter. You have to close the microcatheter maybe 1 centimeter before the apex of the tip. Then push it, then the guide wire is entered into the two lumen. Then you advance the guide wire maybe 1 centimeter, 2 centimeter around. You have to advance the microcatheter into here. Microcatheter here, you can recognize by eyes using the acoustic shadow. This one, coming microcatheter here. So you can see microcatheter here. Then pull out the ST wire, change the guide wire to the soft wire, then put the stent. That is the scenario of the tip detection ADR. This one I did in Taiwan, TTT right, This is a relatively longer CTO case. My guide wire was entered in subintimal space or something reduced. Then I advanced the tip cut opticals here. Then I did TD-ADR using the tip opticals iris. But this one is a conquest, 20 gram. But I could re-enter from here to here. Then I put the stent and refold like this one. So this one, bifurcation region, this part. So I tried to do the angle wiring, but it was failed. So I did a tip detection method, but I did a re-enter from subintimal space the CTO body to preserve the distal bifurcation. So the guide wire tip is maybe it very hard to see, but this one here. Guide wire tip is directed here. Yeah, this here. So clockwise is much better to navigate it. Then I advanced the microcatheter and changed the guide wire to the soft one, and I preserved this part like this one. And the final case is a very calcified LED CTO region. Very calcified. The PCI performed at another hospital, but the conquest wire was fractured. But they could retrieve it using the twist wire. But the patient was sent to our hospital to receive the intervention and no retrograde channels. So I did also the wiring, but it was in vain. So I did start technique, here some channel. So I advanced the gradius, but no microcatheters, balloons could not be entered using the anchor or something. Then I did a knuckle wiring, a base technique, inflation balloon, and change the route the other way, left side. Then knuckle wiring, then open it here, then open here, and I did TD-ADR from subintimal space to lumen, like this one. Then put the stent and refold. So it's very hard, but we could do it using tip detection method. If the guide wire entered into subintimal space or something. So the final one is open vessel. Open vessel, I only recommend you to like this one. If you rotate clockwise, you have to synchronize your guide wire movement clockwise. This is very important. If you can synchronize, your guide wire movement will be improved. So if you get the branch here clockwise, counterclockwise, if the guide wire tip is going to the side branch, you can get it. If difficult, you can also do the tip detection method to select the non-CTO side branch entrance to the tip detection method. This one. But anyway, so in conclusion, the 3D wiring method is a highly precise guide wire manipulation, not only CTO PCI, but also in open vessel PCI. I think that the IPCI, where PCI meets a precision, that's going to be really hit. Okay, so thank you.
The 3D wiring is an excellent concept. Do you think the second operator is also so important? So actually we don't have a good second operator, that is why we are unsuccessful.
But in Japan, in my hospital, the technicians are also okay because I trained them.
I request you send 1 or 2 second operators to us so that I will learn TD wiring